undergraduate career, and she passed out with a second class honors with she had the surgery prize, and she has been a really excellent academic. So without much ado, so let me introduce Vasana, and she'll be talking to you about childhood infections. Over to you, Vasana.
Thank you, Tushara, for those kind words of introduction. First of all, I must thank the President and the Council of PeMSAA, as well as the organizers of these evening talks of PeMSAA, for giving me this opportunity to talk to our own youngsters on and share some of the practice essentials in pediatrics with you all. I wish to talk to you on rational approach to childhood infections. And basically, I will focus on arriving at a reasonable clinical diagnosis based on the symptoms and signs. And what I expect spending this hour and a half or more with y'all is to enhance your competency. So at least stimulate for y'all to improve your competency in arriving at a good clinical judgment, as well as to improve the ability to identify the red flag features in an ill febrile child. Right. So give me a moment to share the screen now.
While Vasana is getting ready with the screen, so the students, now we have to announce that PeMSAA UK has a research scholarship for you all waiting. So please go to PeMSAA website for your details. Okay, Vasana, over to you.
All right. Okay, right. So this is our topic today, rational approach to childhood infections. So please remember that this is not a lecture on any particular infection. I will basically take you through various clinical scenarios, talking about the symptoms and signs, and discussing how you utilize the clinical spectrum of a manifestation of a disease condition will help you to arrive at a reasonable clinical judgment. Okay, now, as you may know, infections is the most common cause for hospital admissions worldwide, and also visits to general practitioners. And infections is the most common cause for under 5-year-old mortality as well. So out of the infections, pneumonias account for about 70% of child deaths, whereas diarrheal illnesses contribute about 9% to child deaths. So according to the statistics of World Health Organization, so these are the figures that we get from 2018, and it's a major problem, especially in Southeast Asian region. So it's important to know about the various clinical presentations of infections, how to recognize them early, and commence appropriate management. So all medical professionals who deal with children should be competent in making a good clinical judgment and make an early diagnosis, because it's crucial to commence immediate management to save the lives of children, to reduce the morbidity as well as mortality. However, having said all that, assessment of a patient, a young infant or a child, could be a challenging task, because young parents can also be very anxious. They may not be able to figure out why their child is ill. So that can cause difficult situations in your practice. So we'll see why right. So these are some of the challenges in the evaluation of an ill child that you may come across. A young child may not be able to express the complaints. He or she may not be able to tell what is wrong with him or her. Therefore, we need to depend on what the parents or the caregivers tell us. And also, that itself makes it difficult to identify the focus of infection. The young child may not be able to tell, mage oluwa ridanawa, mata bade kakkuma tiyenawa, right? So those things, we all have to depend. We need to guess. There's a lot of guesswork in identifying the focus of infection. And at the same time, there are limitations to the physical examination. So you all may have already done pediatric appointments, so you know what difficulties you have already faced, isn't it? So a child may not allow you to examine the abdomen, may not even allow you to touch, right? So sometimes you may have to depend on the observations mainly. So there are limitations to that. And the clinical parameters are also age dependent. With the maturation, with the growth of the child, the various clinical parameters also change. So you need to have a basic knowledge on that as well. So these are some of the children you will have to examine. An infant who is incessantly crying like this, right? Or a toddler who has strange fear and just refuse your examination, or an aggressive preschool child, or sometimes even a grumpy adolescent. You may not always have a good kid like this to examine following the proper technique of examination. Right? Okay, so that is the life of pediatrics. Therefore, it's important for you to develop the competencies during your undergraduate period itself to get a very good history. History taking is very important in pediatrics, starting from the symptoms and the progression of each and every symptom. The evolution of illness is very important to find out. And then coupled by a thorough examination. Remember, your examination should include a careful observation, especially from a slight distance. Then only you will reveal the nasal flaring, subcostal or suprasternal recessions in a child, or paucity of a movement of a limb, right? So observations are important. And similarly, the gait of the child. Only if you get the child to walk, you may realize that the child has a limp due to transient synovitis or something. And also examination of the ears, throat, and also the genitalia may reveal the focus of infection, because the child can't complain, and sometimes the parents also have not revealed what the focus is. Right. And the manifestations, the clinical manifestations of various illnesses also change with age. For an example, the bulging tins anterior fontanelle in meningitis is just limited to the infancy. It's not there in an older child, right? So you need to master all these to arrive at a good clinical judgment, and also to identify what the focus of infection is, and also to guess the organism, because the organisms also have a predilection to various ages, like you see respiratory syncytial virus or a rotaviral infections in infancy, whereas you don't see them in old children. Whereas mycoplasma infection, EBV infection, you see in slightly older children rather than in infancy. And finally, you need to have the ability to identify red flag features, which are crucial on decision making for emergency management and to save the life of a child. Okay. Right, so these are some of the normal values that you need to know regarding infants and children as they grow up. So their respiratory rate changes, and also the heart rate, and the blood pressure, which I have not indicated here. So I'm not going to go through this table, but you need to probably, learn by experience. Okay, coming on to fever, which is the key symptom of an acute infection. Now, although fever is a manifestation of or presenting feature of an infection, it's a very non-specific clinical symptom. Fever can be there in many other conditions as well, like inflammatory conditions, for an example, inflammatory bowel disease, juvenile idiopathic arthritis, right? Or in autoimmune conditions like systemic lupus erythematosus, or even malignancies in childhood, like lymphomas, neuroblastoma can present with fever. But they are like prolonged fevers. So although fever is important, you need to know that it could be a manifestation of something other than infection as well. So when you approach a child with an infection, you need to look at the spectrum of clinical manifestations to identify what the focus is. It could be just a single system involvement, or it could be involvement of multiple systems. Therefore, a thorough history and examination are crucial. Okay, so from now onwards, I will take some clinical scenarios and go through various clinical symptoms and signs and how you approach to a clinical diagnosis. So first we look at how to approach a febrile child with cough and difficulty in breathing. Now the presentation with fever, cough and difficulty in breathing in an infant, the conditions that occur in infancy is different from that what occurs in preschool children and older children. Right? So we'll first see what are the conditions that present with the infective conditions that present with fever, cough and difficulty in breathing in young children. So I will give you a case scenario like this. A 9-month-old infant presents with 3 days of coryzal symptoms and feeding difficulties. And on examination, you find that the baby is febrile with 100 degrees Fahrenheit, mild to moderate fever, has a dry, wheezy cough, tachypneic with a respiratory rate of 60 breaths per minute, has nasal flaring, and also has suprasternal and subcostal recessions. On auscultation, you find symmetrical air entry, vesicular breath sounds, prolonged expirations with bilateral expiratory fine crepitations and rhonchi. So what could be your clinical diagnosis based on this information? So this is one of the commonest infections, respiratory infections you see in infants. So this is none other than bronchiolitis. This is probably, depending on, according to the clinical presentation, this could be moderate bronchiolitis, but you will need further information regarding how badly feeding is affected and what is the oxygen saturation to decide whether this is moderate to severe category. So when bronchiolitis is moderate to severe, it is important to differentiate from another respiratory illness that can present in that age group, the bronchopneumonias, which again is either viral or bacterial, but when it is bacterial, especially, it can have a poor outcome if we don't start treatment at the right time. So it becomes important for the first contact doctor or the house officer or the medical officer who sees the baby first to judge clinically whether this is more in favor of bronchiolitis or a bronchopneumonia. So let's see how we can clinically differentiate these two conditions. Now, in severe bronchiolitis, or basically moderate to severe bronchiolitis, tachypnea is a basic feature, and also the baby will have recessions. You know, infants have very compliant chest walls, so they show a lot of recessions, suprasternal and subcostal recessions. Intercostal recessions are rarely seen in small children. And their fever is mild to moderate, not very high fever, but they are more distressed, right? So they are less ill and more distressed. They are hungry, but unable to feed because of the difficulty in breathing. In contrast, in bronchopneumonia, the babies tend to have very high fever and they are very ill looking. So the fever and the ill look go together. They are tachypnic as well. Recessions, it depends. Recessions may be more marked or average. Right? But remember, the subcostal recessions, they are more prominent in bronchiolitis. So looking at the child, they are less distressed but more ill. And they refuse feeding because they are too ill to feed. Right? Not more because of the distress, but because they are very, very ill. I'm not telling you that it's easy to differentiate between severe bronchiolitis and bronchopneumonia with these findings, because we may not see all these things in a baby, right? So only 2 or 3 features may be present. It's your high index of suspicion makes you the proper clinical diagnosis. Why is it important to differentiate these 2 conditions? One is the decision to admit the patient. If the patient presents with mild to moderate symptoms, if you think this is bronchopneumonia, you immediately need to admit for further evaluation and management. But if it is mild bronchiolitis, you can wait and see, right? And also the management is different, and so are the complications. Now, a few words about bronchiolitis. I'm not going into the details of any particular infection. It's a viral infection. You know the causes like respiratory syncytial virus and even the parainfluenza and metapneumovirus all cause bronchiolitis in infants. They develop difficulty in breathing around about the 3rd day of the illness. They can even present with apneic episodes. And when you examine, you might see a hyperinflated chest. And due to the same reason, the organs can be displaced downwards, right? And the complications point of view, they can develop more hypoxia and will need respiratory support. They will need support for hydration and feeding. And also we have to be vigilant about development of secondary bacterial infections towards the latter part of the illness. So basically the management is supportive care with no antibiotics, unless there is evidence of a secondary infection. Whereas in pneumonias, either viral or bacterial, infants may become very ill, right? So they need, and also rather than push down livers, they have hepatomegaly, right? And they need further investigations to identify the condition and complications point of view. They can develop effusions associated with the pneumonia, collapse, empyremas, and also hypoxia like in bronchiolitis. And we have to treat these babies with antibiotics. Right? So that is why we need to differentiate these 2 conditions. Now, when talking about an older child, a preschool child, or even an older child, we are not dealing with bronchiolitis at that age group. It's more a community-acquired pneumonia or a viral-induced disease. Again, it's important to differentiate a community-acquired pneumonia from just a virally-induced disease because the management is different. The complications you are looking at are different. And also the investigations, the way of evaluation are also different. Right. So in a pneumonia, again, high fever, tachypnea are markedly, the important features, whereas cough may be less marked in an older child. Whereas such a child may complain of abdominal pain due to diaphragmatic irritation or pleuritic type of chest pain. Right? And you may find widespread or localized coarse crepitations depending on the extent of the lung involvement. Now, in contrast, in viral-induced wheeze, a child will present with a wheezy cough, and you might hear the wheezing noises, and you will also appreciate prolonged expirations and widespread bronchi in such a child. Having said this, a child with wheezing, intermittent wheezing, may develop a community-acquired pneumonia, and as a result, may develop worsening of the bronchospasms. Okay? So again, it's your clinical judgment that makes the proper diagnosis. Right. Okay. Right. So what are the red flag features when you deal with a child with respiratory illness? Right. That you need to know how to label a child as tachypneic. So the respiratory rates, the upper limit, you should have an idea about that. And if a baby is tachypneic and feeding is disturbed and there are localized signs and the child is drowsy, which might indicate the child is getting hypoxic, you need to admit immediately for further management and evaluation. Okay, right. So now we are going to discuss about another very common acute febrile illness or an acute infection in children that you see. That is a child presenting with fever and a skin rash. A skin rash, again, in a febrile child may actually point towards the diagnosis itself because certain infections have characteristic skin rashes. So it's important to be familiar about this. Having said that, it's important to note that skin rashes are not always associated with an infection. It could be a manifestation of a pure dermatological condition. It could be a manifestation of an autoimmune disease, and so on. Okay. So the important tips towards a clinical diagnosis when you are dealing with a skin rash is identifying or revealing the extent or the distribution of the skin rash. The commonest skin rash you see is a viral exanther, which occurs centrally involving the head and neck area, the central parts of the body, and spread downwards or spread peripherally. But sometimes the skin rash can be confined to localized areas, like only the lower limbs, or it could be affecting only the palms and soles, extensor aspects. So it's important to note that. And then to look at the mucous membranes for an enanther, right? Involvement of conjunctiva and oral mucosa are important because that will provide the clue to your diagnosis. And then the involvement of skin appendages like hair and nails, and also the extracutaneous manifestations like joint involvement. There are many infections that have skin manifestations as well as joint manifestations. Right? So having that background, now let us go through some scenarios. Okay, right. So look at these pictures and see whether you can figure out what this infection is. I know it's not very easy just to look at the pictures and say what the diagnosis is. But however, say this child presents with fever of about 3 days, very ill-looking, irritable child, refusing to drink or take orally. And mother says the rash started in the behind the neck area and spread downwards. So this is a maculopapular eruption. And when you examine the mouth, you see these white spots in the oral mucosa. Now it's easy. So what is the diagnosis? It's an infant with measles. You may think that, we don't see measles nowadays, but it's not so, because MMR vaccine is given at 9 months. Sometimes infants present before the vaccination. Right? Before 9 months, they may present with measles. And why are we worried about measles is it can be associated with the severe pneumonia and also encephalitis, and can have morbidity and mortality. Right. And these are the Koplik spots. It's a pathognomonic feature in measles infection. So if you come across a very ill child who is presenting with a measles-like rash, don't forget to open the mouth and have a look at the oral mucosa. So this may give you a clue to the diagnosis. Okay, I will show you another picture. So these are 3 different infants. Again, these are measles-like rashes. So they are either macular or maculopapular rashes. And we generally call, give an umbrella term, measles-like rash. So this is more of a macular rash. This, of course, is a maculopapular rash. I know it's a bit difficult to say, but just wanted to show you these pictures. So these are all measles-like rashes. So this is, we call this Roseola infanta. It's caused by human herpes virus 5 or 6. It's a benign self-limited viral infection. Doesn't make infants very ill though. And this is rubella, maculopapular rash. Again, rubella is not a very common infection nowadays because of the vaccination. And I just wanted to tell you, in viral infections like influenza, parainfluenza, they all can present with measles-like rashes, but it's in certain infections, there can be associated complications in other systems, especially in influenza. A child can suffer from a bronchopneumonia, right? So you have to be vigilant about that. Right. So this is an extremely important infection that you need to know. So you can see this child has a flushed face, red lips, and looks very ill. And there is a maculopapular eruption, erythematous rash. And also you see evidence of this Hess's test be done. So you know the diagnosis now. So this is dengue hemorrhagic fever. Right. As a first contact doctor, and in our country, you need to know about dengue infection very well because you need to diagnose, especially in the, it's a seasonal infection, after rainy seasons, you see several cases of dengue fever coming, they occur as epidemics. So in such seasons, any child presenting with fever, you have to actively look for evidence of dengue hemorrhagic fever. So here I'm showing you the convalescent rash of fever, which we call white islands in a Red Sea. Right? So you must have seen this. So the important things. Now, okay, so I will just tell you about this Tourniquet test. So if you suspect DHF, a child who is having a flushed face, irritable, who complains of abdominal pain, right? A child may or may not have an erythematous rash. So the rash is not very common in dengue fever, although it is a known phenomenon. You may not always see a rash, right? So you need to perform a Tourniquet test. How do you perform that? You apply a blood pressure cuff just above the antecubital fossa and inflate midway between systolic and diastolic pressure and maintain that for about 5 minutes and then release the cuff. Wait for 1 minute and in the area where most petechiae are seen, you draw a square of 2.5 centimeters into 2.5, and a positive test is taken when more than 10 petechiae are seen. Okay, right. So you need to know the red flag features to immediately admit when you suspect a child is having dengue hemorrhagic fever. Not all children with dengue fever need admission. If they are taking orally well and if they don't have any features of dengue hemorrhagic fever, they can be managed as outpatients basis, reviewing their full blood counts daily. But however, if a child has these features, they need immediate admission for further monitoring, evaluation, and management. So a flushed appearance with a positive Hesses test and any sort of bleeding manifestation. It may be bleeding gums. Poor oral intake or vomiting is an indication to admit. Reduced urine output. And epigastric pain or right hypochondriac pain may be the beginning of the leaking phase. Right? Features of shock or impending shock are important to identify. I will talk about this later on as well. When I talk about how to recognize a new child, I will talk about shock. And whenever the parents are concerned, if the parents say, my child is not right, then the child is not right, right? So you need to admit such a patient. Okay, right. So having talked about dengue fever, now I'm showing you another common skin rash presenting with fever. So this is chickenpox. Not all children with chickenpox need hospital admission. Most children are managed at home. So generally parents know how to manage, especially when there are grandparents, they know how to manage a child with chickenpox at home. But there are instances that you need to decide to admit a child with chickenpox or varicella infection. So when? Now, these vesical eruptions can affect the oral mucosa and prevent adequate oral intake. So a child can go into dehydration. The other instance is having evidence of a bronchopneumonia, or whether if there is evidence of CNS involvement like encephalitis, meningoencephalitis, you need to admit. So these are not very common occasions, but you have to be vigilant about that. Okay, so this is another benign self-limiting viral infection that you may come across. We call this erythema infecciosa or slap cheek disease. This is caused by parvovirus B19. Generally, among toddlers, they present with 2-3 days of upper respiratory symptoms with mild fever. And on the 3rd or 4th day, they develop this slap cheek appearance and this maculopapular eruption. So it's nothing to worry about. This is a self-limiting illness with no much complications. All right. Okay. This is quite a common condition that you may come across. What is this? So this skin infection erupts as a group of papules around there's a predilection to the nose and mouth area, and they develop into vesicles which eventually rupture into something like this, leaving a honey-colored crusted lesions in that area. Although I said it mostly affects the nose and mouth, it can occur elsewhere as well, but this is the most common finding. So what is this condition? This is impetigo caused by Streptococcus pyogenes. So this is a bacterial infection which needs treatment with antibiotics, generally an oral antibiotic. Okay. So this is another skin rash which occurs in older children mostly, about 5 or 6 year olds or in adolescents. So there is a maculopapular eruption. You can see this is about a 10-year-old girl. So these are the other signs that this child has: generalized lymphadenopathy, exudative pharyngitis, hepatosplenomegaly, and palatal petechiae. So it looks quite nasty, but however, it's a viral infection. So when there is such a constellation of clinical symptoms and signs, it's not difficult to clinically diagnose this condition as infectious mononucleosis caused by Epstein-Barr virus. So again, this is mostly a benign infection, but sometimes can be associated with other system involvement, causing a pneumonia or sometimes myocarditis or encephalitis or autoimmune hemolytic anemia. So not all children with these viral infections need admission, but you need to diagnose these conditions. Then only you will know what sort of complications might occur in this child, right? So you will organize or arrange suitable follow-up to see in a few days' time, to review the blood count, right? So you will be careful about the complications. So it's important to know these symptoms and signs of this infection. Okay, so this is an interesting infection that you will see in pediatric patients. Right, so what do you see here? We call this a white strawberry tongue. You can see the red edematous papillae in a white background, in a white coated tongue, which eventually develops into a red strawberry tongue. Right? So this is a classic conversion which occurs on about day 3 or 4 of the illness. So children have high fever to begin with, they are irritable, they develop this maculopapular eruption, and if you feel the skin, you will have a sandpaper-like feeling, and after a few days, you might see this skin peeling. So what is this condition? And you might also see perioral pallor, but in Asian children, you might not be able to appreciate that. Okay, so this is scarlet fever. I haven't given you a picture of the inflamed pharynx in this child, but if you look at the throat, you might find an inflamed, enlarged tonsils as well. So this again is a bacterial infection. So you need to identify or diagnose this condition because it needs management with antibiotics. So you need to investigate with your blood counts, CRP and all that, and treat with antibiotics because this can have sequelae if you don't treat properly. Because this is the same organism which can cause rheumatic fever, post-streptococcal glomerulonephritis, okay, and also can have many other complications if you don't treat properly. Okay, right. So this is these are some pictures of a toddler. Right. So have a look at these pictures. So you can see blisters, right, on the palm, on the soles, right, and some on the legs as well. Now, if I say the same toddler is refusing to feed, the mother complains, so, my child is not refusing to drink and refusing to eat. So that is why this baby is admitted. Right? So if you look at the mouth, you see some red spots like this in the mouth as well. So what is this condition? This is hand, foot, and mouth disease. It's a common viral infection. Again, we see them as clusters in, when they come, many cases come together, right? So again, you can say it's quite seasonal. It's caused by Kawasaki A virus. The importance is, one thing, these children can get dehydrated because of poor oral intake, they can become quite irritable. And on the other hand, they can develop rare complications like myocarditis. So it's important that you know about this condition and follow them up accordingly. Right. Okay. So this is a spot diagnosis if you see the features correctly. So this is slightly older child who presents with this rash. It's more in the peripheries, not much in the central region of the body, and it's affecting the palms and soles as well. Apart from the maculopapular eruption, there are some petechial rashes as well. So the child is ill, febrile, complains of abdominal pain. So what is this infection? If I say this child's family comes from Dugannava area, it's a rickettsial infection. It's a typhus fever. Right? So characteristically, the rash affects the palms and soles, and sometimes it may not be very erythematous. It's very variable rash, but these are some characteristic features. Typhus fever can also have other organ involvement. Like these children can develop bronchopneumonia, they can develop myocarditis, diarrhea. So many systems can get involved, and they also need treatment, investigation, so need admission for that. Okay. Right. So this is somewhat rare, but I thought of showing this to you because it's caused by a common pathogen. So this is a picture of an older child who presents with this specular rash. I think you can appreciate the central pallor with surrounding serpiginous erythematous areas. So if I say this child presents with fever, a cough, and there is evidence, clinical features of bronchopneumonia. So this is erythema multiforme caused by mycoplasma infection. Erythema multiforme can be caused by herpes simplex virus as well as mycoplasma. So mycoplasma is what is more commonly seen. So it's interesting to know, right? So actually, this is a Caucasian skin. It's not very well seen in Asian skins, but it's good to know that, erythema multiforme can present in mycoplasma infections. Okay, right. So this is an important infection, though rare. It can result in significant morbidity and also can result in mortality unless treated promptly. So obviously you can see this is an ill child. So I hope you can appreciate this perioral pallor, perioral fissuring. Here also you can see, right? And around the eyes, around the nose. So ill febrile child having this perioral or periorificial lesions. What is the diagnosis? And the entire skin is red, erythematous, tender, right? So this is staphylococcal scalded skin syndrome caused by exfoliative toxin producing Staph aureus. So you need to recognize this and evaluate and treat with appropriate antibiotics to prevent complications. So I hope you all have learned that the Nikolsky sign is going to be positive in these patients, where when you apply slight pressure on the skin, there will be epidermal separation, which leaves denuded areas of denuded skin. Right. Now talking about acute febrile infections will not be complete unless I talk about this as well. Although this is not an infection, it can easily mimic an infection, right? So just pay attention to these, the spectrum of clinical manifestations which I've shown you here. So you can see this non-purulent conjunctivitis, red lips, red tongue, red mouth, cervical lymphadenopathy, and also irritable child having swollen feet and hands. And also there is and erythema around the BCG scar. So this is a picture taken after a few weeks of the illness, which shows periungual peeling. So what is this condition? So somebody who doesn't know about this condition can easily think that this is an infection. So this is Kawasaki disease. A child can, below 5 years, like, even an infant or even up to about 3 years, they can present with fever of 4 or 5 days duration, extreme irritability, poor feeding. You may actually think that this is a CNS infection or severe sepsis. And if you detect these clinical features, it won't be difficult for you to clinically diagnose Kawasaki disease. It's important to diagnose this condition because it's a vasculitic condition which is associated with coronary arteritis and can have devastating complications unless you detect this and treat rigorously with immunoglobulins or steroids or whatever is according to the guidelines. You can treat them and you can prevent the complications, right? So it's very important that you know about this condition, which is exclusively in pediatrics. Okay, right. So now we have gone through an array of acute febrile infections with skin manifestations. Now let us move on to a child presenting with fever, irritability, and drowsiness. Right. So when parents bring their infant or the young child with these symptoms, you have to be very vigilant, right? So the parents can't figure out why their child is having fever and so irritable. So you need to take a very good history to find out whether the baby is irritable and drowsy in between fever as well. If so, it's very significant. It indicates CNS irritation. If the child is ill and irritable only during the fever, but very well in between fever, playing and eating, you don't have to worry too much. But in between fever, if the child is not right, that is significant. Okay, so it could be a CNS infection, it could be meningitis or encephalitis or a meningoencephalitis as well. And at the same time, this fever, irritability, blissness can occur in other conditions, especially in urinary tract infections, because, when there is dysuria, the child can't complain. It's hurting when I'm peeing, right? The child will be irritable. So we have to discover that it is due to a urinary tract infection, right? Similarly, with conditions like acute otitis media, a child can be irritable, but in between fever, child is generally well. Right. So what are the important things in the history that you need to focus to get a clue whether this is a CNS infection? So as I said, irritability in between fever, refusal of feeds, and lethargy, again in between fever spikes. And also some parents, if you ask, they may say they have noticed some abnormal movements. Subtle seizures can occur in children which are not very well evident, like lip smacking, abnormal blinking of the eyes, right? Swallowing movements, right? And also staring episodes. unless you inquire from the parents or the caregivers, they may not come out with these things. Right? And also when you examine in an infant, it's important to feel the anterior fontanelle and elicit the neck stiffness, Brunski's sign and Kernig's sign and all that. Right? Not all these features may be present in all patients with meningitis or encephalitis, but the presence of one or two clinical features should raise your suspicion whether this is a CNS infection. Okay, now can you distinguish between meningitis and encephalitis clinically? Now, meningitis is mostly caused by bacteria, but can be viral as well. But encephalitis is usually a viral infection. So meningitis is meningeal inflammation and encephalitis is infection and inflammation of the brain matter. So it's quite difficult clinically to distinguish between meningitis and encephalitis, but there are subtle features that may raise your suspicion with regard to differentiating between these conditions. Right? So meningitis begins like a flu-like symptoms lasting for a few days, and then the child becomes increasingly unwell with vomiting, drowsiness, photophobia may or may not be there, and refusal of feeding, neck stiffness, and all that. In contrast, encephalitis can be insidious in onset. Fever may not be a very prominent feature at the beginning, but headache may be quite prominent, especially in an older child. He or she may complain of severe headache. And parents may observe behavioral changes, may not be persistent, but time to time changes in the behavior, child becoming confused and disoriented time to time, and may also develop focal or generalized tonic-clonic seizures. Right, okay. So now these features do not completely differentiate between these two conditions, but it will help for you to arrive at a, your clinical judgment. Whatever it is, if your patient has these features, will need immediate attention. Okay, so I'm not going to too many details of meningitis and encephalitis. I will move on to the approach to a child with fever and excessive crying. Now, these clinical manifestations slightly overlap. Now, irritability, excessive crying, right, they can go together, but there are certain conditions that we consider in a child who is presenting with excessive crying. Right? They are not that irritable, but they are febrile and have inconsolable crying. And parents can't figure out why their babies cry. So as doctors, it's our duty to find out what's the cause of this. Right, okay. So what am I showing you here? It's inflamed, enlarged, very angry looking tonsils. So unless you examine the mouth with a tongue depressor, you might not visualize this. Just opening the mouth and, baba, akiyanna mata kata balanda, that might not show tonsils. So if you really can't find a focus in the febrile child, you have to use a tongue depressors to examine the throat. Otherwise, you won't see this. Similarly, a child who is excessively crying and parents don't know why, and you also don't know why, right? Unless you examine the ears, look at the tympanic membrane, you won't see this picture. So this is acute otitis media. And if you directly, ask some direct questions from the parents, has your child been pulling the ear time to time during this fever period? Then the mother will remember, doctor, sarin sare kana nang adinawa dakka. So that gives you the clue to the diagnosis. So this is acute otitis media. So look at this baby. He's nicely moving the right leg, but you can see there is paucity of movement of the left leg. He's keeping the hip slightly flexed and it's kept still. So unless you observe this baby carefully, look at the movements and then ask the mother, did you notice any reduction in movement of this limb? You won't be able to find the focus quickly. Right? So that will all delay your diagnosis. So this is septic arthritis of hip, and similarly, septic arthritis of the shoulder joints. Also extremely difficult to diagnose unless you specifically look for these features. Right. So as doctors who are going to see children, you have to be well equipped with some toys. You will have a torch which is working, right? Not that you have to shake all the time or you have to ask for somebody else for the torch, right? So you have the torch that is working with working batteries, right? So you need oroscope, tongue depressor for proper examination, right? Now these conditions that I'm going to show you here may not have fever, but they can present with an febrile illness as well. So what is this? It's a hernia. A strangulated inguinal hernia. Unless you look at the genital region or the perineal region, you may not detect this. Similarly, in a baby who is coming with excessive crying, especially episodes of excessive crying with arms and legs flexing towards the body, and the parents complain the stools are different, and you ask to look at the diaper and you notice these blood-stained stools, you may not detect an intussusception, right? Okay, right. So if you are not conversant, if you are not confident with your clinical signs and symptoms, it will delay the specific management of your patient and increase the morbidity and mortality. And also it will lead to complication development, and adding to all that, the distress of the parents also worsen, right? Okay, right. So before we move forward to about assessment of a critically ill child, I just want to talk a few words about parenteral diarrhea. Now, in my talk, I didn't focus on acute febrile illness presenting with loose stools because of the time factor. But I would like to tell you a few things about the parenteral diarrhea. Parenteral diarrhea is a child having loose stools without evidence of a GI infection. Right? It is a manifestation of extra gastrointestinal infection, like the most common infections that a child presents with fever and loose stools but not having a GI infection are urinary tract infections, acute otitis media, and meningitis. Right? Sometimes infections like influenza, right? Respiratory tract infections, even bronchiolitis can have parenteral diarrheas. So it's good to know about this, because it can just mimic a GI infection, and you may just not admit the child for evaluation. Okay, right. So my talk on clinical approach to childhood infections will not be complete unless I talk to you about the red flag features to identify in a very ill child. Right? So a child may present with any symptom: fever, vomiting, loose stools, right, skin rash, reduced activity, drowsiness, irritability. And as you see the child, you get a feeling that this child, there's something wrong, not right with this patient. So then you need to perform a rapid clinical assessment to identify signs and symptoms of early compensated shock, which can be easily missed unless you do a proper assessment, right? Because early recognition of shock is crucial for saving the life of the child. And for that, you need to have a very high degree of suspicion and also a knowledge on the baseline parameters in children. So you do this rapid assessment to identify potential respiratory, circulatory, and neurological failure. So the algorithm, you follow this algorithm: airway, breathing, circulation, disability, and exposure. A, B, C, D, E. Right? So it's very straightforward. I'm sure you already have learned about these things. So this just to recap. So how do you assess the airway and breathing? Right? So if the child is vocalizing, you can assume the airway is patent. If not, you have to perform look, listen, and feel for the airway movement, and then institute airway opening maneuvers. So I'm not going to talk into that detail. You assess the breathing, right? Whether there is severe respiratory distress, respiratory rate, whether the child is tachypneic or bradypneic, whether there is any audible stridor, evidence of upper airway obstruction or wheezing, right? And look for other features like cyanosis, auscultate for entry, and the saturations. So assess your airway and breathing. This won't take more than a few seconds, right? Then your circulatory assessment. Look for the peripheral circulation, central circulation, right? Look for the pulse volume, and then the capillary refill time. You should know how to check the peripheral as well as the central capillary refill time. So this is what is shown here. You press on the skin and count up to 5 seconds. And then you take off your finger and measure the time for refilling. Again, you count up to 5 seconds, right? So it has to be less than 2 seconds. If the cap refill time is more than 2 seconds, it's delayed, right? And when you count the heart rate, again, you need to know the upper range of children. So if the heart rate is more than 200 in an infant, it's abnormal, or more than 150 in a child, it's abnormal. So immediately you need to take ECGs. So it could be an arrhythmia. Right? Okay, then you assess the disability, that is for the neurological failure, and at the same time you do a blood sugar measurement to assess whether there is hypoglycemia. For disability assessment, you do your AVPU score rather than assessing the GCS, which is time consuming. You look at the response of the child, right? If the child is alert, that's fine. If the child responds only to voice, or responds to pain or unresponsive, so that is how you look for the AVPU score. And adequately expose the child to identify any rashes that are associated with the illness, and look for any other features that are relevant. So what are the features or clinical signs of compensated shock? If a child is agitated or confused, that indicates there may be cerebral hypoxia. Presence of pallor, tachycardia, right? So tachycardia, cold peripheries, delayed cap refill time all indicate that there is impending circulatory failure. Right? Reduced urine output, right? And then with the normal systolic blood pressure, if the diastolic blood pressure is increased, that could be due to systemic arterial resistance due to volume contraction. So all these features may indicate compensated shock. So it's cold shock. So a warm shock is rare to find in children, where you see a high cardiac output and flash capillary refill. So there is peripheral vasodilatation. So I'm not very important in this presentation. Right? So however, it's important to recognize early features of shock in an ill febrile child. So coming back to my previous slide, the competencies that you need to develop are extremely important to make you confident to evaluate children. Right? So going through again the history taking is, you have to develop your skills in history taking, extracting information what are necessary for you to come to a clinical judgment. Your examination, which includes the careful observation, even before touching the child, right? And your knowledge on the changing clinical parameters according to the growth of the child are important for your clinical judgment. Okay, and then identifying the red flag features are extremely important. So that comes towards the end of my presentation. So what I suggest to you is that you need to associate with children as much as possible, understand their behavior, learn how to talk to them appropriately, then pediatrics will be easy for you. So these are some of your seniors who did pediatric appointments with us. Right? So you have to be with children to learn, to examine them properly, and to extract information. Right? So if you develop the competencies, then you can become a confident doctor. You will feel safe in your part. And on the other hand, you will do justice to sick kids as well. So that's all I have to say this evening to you. So if you have questions, I can take up. So thank you very much for your patient listening.
Vasana, there are some questions they've asked in the chat box.
Okay, yeah, I'm going through the chat box. Right, so bronchial asthma. So I think this is about the 9-month-old baby, bronchial asthma, right? So now what I've got to say is bronchial asthma, we don't diagnose in infancy, but at 9 months, baby can present with wheezing. But however, bronchiolitis is the commonest infection that presents as wheezing. I mean, wheezing as a presentation of bronchial asthma is not seen in infancy. So it's more towards the older children, right? So after 1 year. But a baby who has suffered from bronchiolitis in infancy are more prone to develop wheezing thereafter because their airways become hyper-responsive. So they can present repeatedly with wheezing episodes. But originally to present with bronchial asthma is unlikely in infancy. So expiratory, fine expiratory crepitation. So it's more end inspiratory rhonchi that you see in asthma. What does prolonged expiration imply? Bronchospasms, right? So in bronchiolitis, it causes airway inflammation, especially the terminal, the bronchioles. So that causes airway inflammation and narrowing of the airway. So that is what causes prolonged expirations. Right. So what I meant by localized is like global pneumonias. You see you auscultate the lung signs in a particular area of the lungs. So that is what I meant. Presence of bronchial breathing. Although I said, I mean, the bronchial breathing, those features are not very common in young children. You may appreciate bronchial breathing in older children, right? But in infants, it's quite uncommon. Is there a difference in complications between viral and community-acquired pneumonia? Now, the complications point of view, community-acquired pneumonia due to Streptococcus pneumoniae could be a lobar pneumonia. And in such situations, the complications are like pneumonic effusions, development of an empyema, right? Whereas viral pneumonias are more widespread bronchopneumonias. So they may develop hypoxia rather than developing localized complications. Or viral bronchopneumonias can get complicated with secondary bacterial infections. In older children who present with severe viral pneumonias, who go on to have temperature spikes, we need to suspect secondary infection with Staph aureus. Right? So they can develop Staphylococcal pneumonias due to secondary infection. What is meant by maculopapular rash? It's the interspersed macules with papules. So macules are flat. They are not palpable. Papules are the palpable lesions. So they generally in exanthems, they coexist, macules and papules. Okay, I hope I'm giving you the answers that you are satisfied about. If you have any questions, you can ask again. You can actually switch on your audios and talk to me. Next question. Morbilliform and measles, yeah, they are similar. They are quite similar, the same terms. Should Koplik spots be there to diagnose measles? Not necessarily, but Koplik spots, if they are there, they are pathognomonic of measles. But measles does not always, or 100% have Koplik spots. What about hand, foot, mouth disease? Are they common these days? We didn't see hand, foot, mouth these days, but it's a very common infection. So time to time, you see cases. I mean, in a year, you see several cases of hand, foot, mouth disease. So I must say it's quite a common infection. Right, what else? Are we giving dexamethasone for all infants more than 6 weeks who is suspecting of bacterial meningitis or only in Hib meningitis? Yeah, dexamethasone is advisable not only in Hib meningitis, in older children, we give dexamethasone, but in infants, when the anterior fontanelle is open, it's not very common practice to give dexamethasone to all children. But in older children, of course, if you highly suspect of meningitis, we can give dexamethasone. We give dexamethasone to curb the cytokine storm, which is caused by the cell lysis, the lysis of bacteria, once we give the antibiotics. But I don't know whether, it's not practiced all the time, but we can. What does Tushar say about this?
Sorry, Vasana, I didn't get that question.
Right, so giving dexamethasone for all infants more than 6 weeks suspected of bacterial meningitis. Although it says, sometimes in infants, we don't start with dexamethasone, isn't it?
Yeah, so neonatal period, no, but after that, yes, along with the first dose of antibiotics, yeah.
Okay. How to identify parenteral diarrhea, right? So now when you see a patient, if it is purely, the symptoms are purely are relevant to your GI system, then it's most likely a gastrointestinal infection. Say a child is presenting with fever, vomiting, and diarrhea, then it's more like a gastrointestinal infection, and especially if it's offensive diarrhea, if it's greenish. I mean, there are certain indicators, right? But however, a child is also having other features, like there is cough, right? Child is pulling on the ear, the child has a sore throat, then you have to think whether this is a parenteral diarrhea rather than a GI infection. Right? So to differentiate, you may do a stool full report. Right? And if you find another focus like acute otitis media or bronchiolitis, that this is parenteral. Right. So differentiating bronchiolitis from first attack of asthma. So I think I addressed this. Asthma usually don't present during the infancy, but they can present with easily reactive airways with viral infections. Sometimes it's difficult to differentiate between bronchiolitis and wheezing, but it's the evolution of the illness that will give you the clinical judgment. In bronchiolitis, it becomes severe. They will need supportive care, feeding support and fluids and all that. Whereas in a wheezing episode, children won't become that ill. So it's the clinical judgment what matters there. In impending shock, what is the first sign can appear from mention? Impending shock due to sepsis, maybe the cold peripheries, delayed capillary refill time may be the first indicators, along with tachycardia. Right? So maybe tachycardia is the first symptom. Persistent tachycardia, even without fever. Right? Right. So it's a constellation of manifestations like tachycardia, prolonged tap refill time, cold peripheries, they all go together. Right? Is there a place for antibiotics in bronchiolitis in order to prevent secondary infections? Obviously not. So bronchiolitis is purely a viral infection. If all the symptoms and signs tally with bronchiolitis, there is no place for antibiotics, and you can't prevent secondary infection by giving antibiotics. It will just destroy the normal flora. So it's just a supportive treatment, but you have to monitor babies with bronchiolitis to early detect any evidence of secondary bacterial infection. Because you manage your bronchiolitis patients in the same ward along with other infections. Right? And the same medical staff handle all these babies. So there can be cross-infections and a baby with bronchiolitis having a weak respiratory tract can always attract bacterial pathogens. So the earliest indicator of developing a secondary bacterial infection would be increasing the development of fever spikes, fresh fever spikes. Right? And the baby's oxygen requirement goes up suddenly. Right? So then you have to suspect whether this baby is developing a secondary bacterial infection, and maybe you do a chest x-ray at that point, right? And start antibiotics then and there. If there is erythema around umbilicus in day 5-day-old child, need a hospital admission. Well, erythema around the umbilicus may indicate infection. Right? So that is why you worry about. So you have to see this child carefully. Maybe you do not admit on the day itself unless the baby has fever. But if there is induration around the umbilical stump, apart from erythema, and also if there are pustules, you may admit then and there, but otherwise you may observe this patient. But this may be the indicator of developing an infection which has, which is starting from the umbilical stump. So you have to be very careful, may need admission. Can bronchiolitis present with dry cough? Yes, of course, they present with dry cough initially. They may not always have a wheezy cough, right? This is a good question. So the commonest symptom is the dry cough, not the moist cough. Does apply to children? Okay. I do not deal with, diagnosis and management of sepsis in children. It's entire, topic in sepsis. Maybe we do a session on sepsis in children, right? So although we do not apply Q so far directly, we utilize the contents of this in diagnosing sepsis in children as well. Does the skin rash appearing in IMN with EBV help differentiate it from similar but more sinister pathologies like leukemia? Okay, right. So what we see in IMN is a maculopapular eruption. What we see in leukemia, acute lymphoblastic leukemia in children, is the petechial rash. So it's quite different, right? So in leukemia, you do not see a maculopapular rash. So they present with lymphadenopathy. Certain features can overlap in infectious mononucleosis and leukemia, because I think you are talking about this because of this lymphadenopathy and also organomegaly. But in leukemia, in addition to other findings, you will see pallor, and more than hepatomegaly, it will be more splenomegaly and obvious petechiae, rather than what you see in infectious mononucleosis. So certain clinical features are different. But lymphedema point of view, it's important that you consider leukemia in your differential diagnosis. Very good. Febrile illness following vaccination, is it not all significant, or when do we consider it to be significant? Fever occurring within first 24 hours of vaccination could occur, especially after pentavalent and also after JE vaccination. It's not very significant. Sometimes children can develop febrile convulsions, which will need hospital admission. Otherwise, if they develop very high fever, it's an indication to notify. So I think you all have seen in your grey book, development of high fever within first 24 hour vaccination has to be notified. So it is significant, right? But having mild fever, we don't have to do anything about that. If a child presents with diarrhea found to have acute severe malnutrition, will we take that as a complicated acute severe malnutrition? Okay. So in acute severe malnutrition, diarrheal infections are common, and the child can decompensate with the diarrheal illness, right? So there is no entity called complicated acute severe malnutrition, but acute severe malnutrition with diarrhea, right? So it has to be, it's an emergency, right? It's an emergency. This child needs fluid resuscitation, electrolyte management, hypoglycemia, hypothermia, There can be superadded other infections. There could be bacterial infections. So this particular patient will need resuscitation, stabilization phase, and rehabilitation. Right? So it's quite a severe condition. We consider it as an emergency. Okay. Since you mentioned about warm shock, does disappearance of line of coldness always indicate improvement of the shock? Not really, right? But if the child was in cold shock, improvement with fluid resuscitation indicates that the child is improving, but it's not an indicator in warm shock. In warm shock, you won't have a cold line. There will be peripheral vasodilation, warm peripheries with flash cap review. So the disappearance of a line of coldness is not important in the warm shock, right? So we have to go by the map in warm shock. How to identify autoimmune encephalitis and viral encephalitis by CSF report? It's not very straightforward. You can't diagnose, you can't differentiate the two conditions. You will only see lymphocytic predominance and increased proteins only in encephalitis, but in autoimmune encephalitis, we need to do the autoantibodies, which will be absent in viral encephalitis. And also EEGs may be helpful, and so will be the imaging studies. So it will be difficult to differentiate. So the presentation of autoimmune encephalitis and viral encephalitis are slightly different, because autoimmune encephalitis has a very insidious onset rather than viral encephalitis. It's very subtle at the beginning. There could be subtle behavioral changes, speech problems, and neuropsychiatric manifestations, right? Whereas acute viral infection is an acute infection. Right? So just a few days of presentation. I hope I gave you a reasonable answer. If you have any doubt, you can ask again. In pneumonia, do clinical symptoms settle before improvement of X-ray features? Of course, X-ray features take time to improve, at least 6 weeks, it says. So we don't have to be doing frequent chest X-rays unless we are looking for a complication. Yeah, so this is a good question. So we go by the improvement of clinical signs. Nowadays, we restrict taking chest X-rays. So there's no point in doing a repeat chest X-ray to see whether there is an improvement. But if there was an effusion, if you are monitoring an abscess, then maybe you do X-rays, including lateral X-rays, to look for complications. What's the reason for rash appearing after settling a fever of 3 to 4 days? That, of course, I don't know. The reason for rash appearing after settling a fever of 3-4 days. That's the evolution of symptoms of those illnesses. So I don't know a particular reason for that one. Can encephalitis cause headache because there is no pain receptors in the brain? Well, encephalitis causes, it can cause headache, maybe associated inflammation around vessels, not the brain matter, but maybe raised intracranial pressure can cause headache, not just the brain matter. Yeah, it's not because of the brain matter. What are the conditions that cause rash after fever settled? Okay, so the same answer I have to give because I don't know any particular reason for that. That's the known evolution of some of those viral infections with rashes. Can bacterial meningitis have severe headache? Yes, they can have. Could be due to multiple reasons. One is increased intracranial pressure, and again, meningeal inflammation itself can cause severe headache. The thing is, the children or the infants, they can't complain. I mean, even an older child may not be able to express properly about the localization of the headache. If the parents present with a non-febrile and fairly normal child with rashes similar to erythema multiforme, then should we need to consider it as a fungal, maybe a ringworm infection? Yeah, non-febrile child, ringworm infection has a very specific appearance, isn't it? So it has peripheral papules, central clearance with erythematous margin with papules. So it's different, right? So I would like to go through some pictures of ringworm infection, Tinea corporis, and erythema multiforme. Erythema multiforme, it's just a macular eruption with central palo and surrounding erythema. Madam, is soles and palms affected in scarlet fever? The exanthem does not involve palms and soles. Is strawberry tongue seen in both scarlet fever and Kawasaki? In Kawasaki, what you see is entirely extremely red tongue, not the strawberry tongue. Strawberry tongue is quite specific for scarlet fever. Yeah. Can acute otitis media with fever and chills? Fever and chills are very non-specific, right? So you can't say, I mean, there is no relationship between acute otitis media, fever, and chills. So they all can be there together, right? But more specific thing would be the child pulling the ear or an older child complaining of the ear, right? That those may be more specific. But I can't say that fever and chills are not there in otitis media. Can we take chicken pox as measles-like rash in early stage of chicken pox? It's more like maculopapular rash. Not really. These are very different. Measles is a viral exanthem, which is quite profuse, right? It starts with generalized erythematous maculopapular rash, whereas chicken pox is quite scarce. The eruption is not very widespread as in measles, right? So there are specific papules with surrounding erythema and they develop into vesicles, right? So it's quite different. You won't get mistaken for chicken pox thinking that this is measles. If we are suspecting meningitis, do we start antibiotics or wait until lumbar puncture? Okay, that's also a good question. If you really suspect meningitis, you have to start antibiotics as soon as possible. You need to think whether there are contraindications to lumbar puncture. If it is a suitable time of the day where you can get the results of your investigations immediately and your seniors are around, you may go ahead with a lumbar puncture, right? But you have to be sure that there are no contraindications to lumbar puncture. So you have to read about what are the contraindications to lumbar puncture. Okay, so I'm not going to tell you. So maybe that's homework for you. Find out what are the contraindications. If there are no contraindications, you go ahead with lumbar puncture and then confirm your diagnosis. and then start antibiotics. But there are many situations where you can't wait until you do a lumbar puncture. Maybe it's middle of the night that you get the patient and you really suspect meningitis. So preventing complications is the most important thing. So you start your antibiotic and at your earliest, you perform the lumbar puncture. And also say there are contraindications. Say a very ill, very septic child, unstable. There are features of raised intracranial pressure, like extremely drowsy, irritable child. You will have to wait, right? Then you start your antibiotics as soon as possible, and then you do imaging. In an infant, you can do ultrasound scan of the brain. In an older child, you may do NCCT brain, even in the night. Then you perform your lumbar puncture. So it's not necessary to do the lumbar puncture and then start antibiotics. Your importance is your patient to treat. How to differentiate impetigo from molluscum contagiosum? Okay, right. So molluscum contagiosum is usually generalized. They have central umbilication. They don't have surrounding erythema, and they also won't. What is this? They won't break, right? They won't break and leave crusted lesions. So they are very rubbery lesions with central umbilication, and there is no surrounding erythema. Children are not ill. There won't be any fever. It's a self-limiting, benign viral infection. What is the exact age of closing anterior fontanelle and posterior fontanelle? There is a range. There is no exact age as such. So between 15 to 18 months, anterior fontanelle completely closes. Posterior fontanelle usually closes around 6 months of age, but there is a wide range. In some children, in some infants by 1 year, anterior fontanelle is very, very small. You can't perform, I mean, you can't really assess whether there is a bulging anterior fontanelle. Right? However, by 18 months, it's completely closed. So if the anterior fontanelle is open beyond 18 months, it's abnormal. How to differentiate scarlet fever from Kawasaki? Well, it could be difficult, at the clinical presentation. You may have to do certain investigations. Right? Having said, scarlet fever occurs in slightly as Kawasaki disease you see in younger children. So in infants, children below 3 years of age, Kawasaki disease is more common, whereas scarlet fever you see in children generally about 3 years of age. Right? So, however, atypical presentations of Kawasaki disease can present beyond 3 years of age, even around 5-6 years of age, you may see children with Kawasaki disease. Then it may pose a dilemma. Then you have to evaluate the patient. Right? Okay. You may not be able to go by your clinical judgment alone in such situations. But it will be really good to narrow down your clinical diagnosis into 2. This is either scarlet fever or Kawasaki disease. But in scarlet fever, this non-purulent conjunctivitis, there are certain features that are not there in scarlet fever. And also, if you see this classic rash, the feeling of the sandpaper-like feeling on the skin, they are quite typical of scarlet fever, right? But if you have a suspicion, you will have to investigate. You will have to do your counts, ESR, CRP, and then even a 2D echocardiogram to see whether there is evidence of coronary vasculitis. What is the reason for hepatomegaly in pneumonia? When there is systemic infection, pneumonia can be associated with septicemia, then the patient can develop hepatomegaly, right? Any serious infection can lead to hepatomegaly, especially, I mean, it's seen in children. So, right. But in bronchiolitis, it's more a displaced liver. What is the treatment for common cold and coughs in infants? Right. So there is no treatment as such. It's supportive management. I mean, the most difficult situation with common colds and coughs in infants is the congestion, nasal congestion. Now, infants are obligatory nasal breathers. They can't breathe through the mouth. So when their noses are blocked and congested, they find it difficult to feed, right? So they can become dehydrated, they become very irritable. So we can use nasal decongestants like normal saline nasal drops, right? So that reduces the inflammation and clears the noses. And for cough, we don't give anything really. So if there is vomiting, we may use some antiemetics like domperidone, because the cough and cold can aggravate reflux. But otherwise, we don't give any particular treatment. What is the type of shock these babies get, like distributive or cardiogenic shock? It's in septic shock, it's mainly distributive, right? But if there is an arrhythmia, they can go into cardiogenic shock. So all these questions regarding shock indicate that we need to have a session on sepsis and shock. So we'll try and organize one for you. What is the pathology behind the parenteral diarrhea? There are many descriptions, so mostly it is cytokine related parenteral diarrhea. That is what my understanding is, but there may be some other reasons as well. It's mainly the cytokines, right, that causes intestinal inflammation and diarrhea. Need to use 75 in SAM. Not really, because F75 is not available for us now. We can prepare a similar formula to F75 according to WHO instructions. But what we do is we give we rehydrate and then start on diluted formula and gradually build up on the concentration. Right? We do not have F75 formula for us, but having said that, it can be prepared. So there are WHO manuals giving instructions how to prepare. But the problem with us is preparation, the clean preparation, hygienic preparation is a problem. Can identify clinically HIV infected baby. You can diagnose HIV infection. You can only suspect, right? So if your social history is suggestive of an exposure of the patient, right, then you really have to suspect, right? But it's not a clinical diagnosis. You can only suspect it's by patient. Yeah. So a child presenting with recurrent severe infections or unresolving pneumonia or continued fever, right? So in such instances, there are situations we consider HIV. A child who is behaving like an immunodeficiency, right? Having recurrent pneumonias, recurrent meningitis, right? Failure to thrive. Then you need to assess your social history very thoroughly and investigate appropriately. Is obesity an indication for hospitalization in dengue fever? I must say yes, because obesity, dengue can become very severe in obese children. Detection of shock can become a problem. Again, fluid management is difficult in obese children. So it's good to admit. If a child was diagnosed with ITP, do we give platelets? It's out of the focus of my talk. Immune thrombocytopenic purpura, there are only very few indications for platelet transfusion. Generally, platelets are not given for these children because whatever the platelets we give, they will immediately get destroyed unless there is life-threatening bleeding with very low platelet counts, like less than 3,000. We don't give platelets to these patients. Do we need to give prophylactic antibiotics for UTI? Not all the time. There are only a few situations where prophylactic antibiotics are indicated. So I will hope, I think this was asked by, not by a final year student, because I hope final years have already learned about UTI guidelines now. So we give prophylaxis only when it is indicated, right? Not for all UTIs. But I'm not going to the details of UTI here. Okay. Should vaccine be given after developing specific disease for that vaccine? Yes. Yeah. Even if a child develops measles, child may not develop lifelong immunity. So we have to vaccinate. So vaccinations with boosters will give the lifelong immunity. The wild type infection may not give the full immunity. In GBS, the lumbar puncture is done at 10th day to see cytoprotein dissociation. That is, what is this, Guillain-Barré syndrome. Why is it done on the 10th day but not early? We don't do the lumbar puncture very early because the patients are not stable, but I don't know whether there is any particular day to do. We don't do in the acute situation. I may have to check on this. And the last question. In acute gastroenteritis, sodium concentration of stools is high. Yeah, there is loss of sodium in stools. Yes. Okay, right. One more question. Is PCV 30 currently given to patients with pneumococcal vaccine? Is PCV 13 currently given to pneumococcal meningitis? No, we don't have the polysaccharide vaccine. It's time to time available. What we give is the conjugate vaccine. That is the pneumococcal vaccine we give at 2 for 6 months as a non-EPI vaccination. Polysaccharide vaccine is indicated before probably organ transplantation and so on, and in adults. But to prevent pneumococcal meningitis, we give the conjugate vaccine. It's not the polysaccharide. Is that what you mean? Right? So we give the conjugate vaccine to prevent pneumococcal meningitis. Right? The polysaccharide vaccine is indicated in adults and prior to organ transplantations. Can electrolyte imbalance occur in acute diarrhea? Yeah, because there is electrolyte loss and also due to poor oral intake. due to so many reasons, electrolyte imbalances can occur. Yeah. Does tiptoe walking in a 2-year-old need further evaluation? A tiptoe walking in a 2-year-old could be a normal finding, right? So you will have to follow up this child. Does not need evaluation immediately, right? But if this persists, you know, even after roughly up to 2 years is the time that this tiptoe walking start disappearing. If tiptoe walking persists beyond 2 years of age, you will have to assess for the presence of diplegic cerebral palsy. You can assess along with the other gross motor milestones as well, right? You will have to do a neurological examination, but not just at 2 years. At 2 years of age, this could be a normal development. Okay, so I think that's about it. Okay, yes, Tushara, so I think I have answered as many questions as possible.
Yeah, so we'll call it a day, isn't it? So if you have students, if you have any more questions, I'm sure Vasana won't mind answering them through emails. Will that be okay, Vasana?
Yeah, that's fine.
And then we'll call it a day. So thank you very much, Vasana, on behalf of PeMSAA for taking time to give a nice talk to students. I'm sure they have enjoyed it and asking so many questions. Thank you for answering the questions as well. So again, a reminder to the students, please consider taking associate membership and you can help your juniors to come by. Okay, with that, we'll stop this session today. Okay, thank you very much.
Thank you, madam.
Thank you. Thank you.
Thank you.
Thank you, madam.
Thank you very much.
Thank
It was a pleasure talking to you.
Thank you, madam.